Okay, my name's Ed Howard. I'm with the Alliance for Health Reform, and I want to welcome you on behalf of Senator Blunt, Senator Rockefeller, our board of directors, to today's program on the implications of a growing trend in America's health insurance market, that is, offering consumer provider networks that exclude certain doctors, hospitals, and other medical providers. Now, some people call that a narrow network. Some people call it a value-oriented network, and a lot of people call it controversial. Some of the changes that are brought about by the reform law made it harder to hold down costs using some of the traditional methods, making sure all policies covered things like maternity benefits and that a pre-existing medical condition didn't exclude a person from getting covered. And these new slimmer networks are a partial response to that set of changes and therefore the dynamic forces that are at work in the insurance marketplace. They're designed to help hold down costs of care and thus insurance premiums while protecting or improving quality. But some folks worry that these networks hamper provider choice or keep a patient from continuing treatment using the doctor or health facility that they've depended on. And today we're going to take a closer look at those concerns and at the efficacy of these new networks themselves. We'll also hear about some of the efforts to regulate them. And we're pleased to have as a partner in today's program, WellPoint, which among other parts of its business operates Blue Cross plans in a dozen states and offers coverage for 1 in 9 Americans. A couple of logistical items before we get started. If you're in a mood to tweet, the hashtag is Network Adequacy, and if you need Wi-Fi to connect before you tweet, the instructions on how to do that are on the screens and I think on the tables in front of you as well. Now, we've had some adjustments to the program, therefore some of the documents in your packet may not be quite up to date. If that's the case, you can get the most up-to-date versions on the Alliance website, which is allhealth.org. And in the packets that you do have, there are some important pieces of information, including speaker bios, a new improved speaker bio list, with a lot more information than you're going to get from the verbal introductions. There's a materials list, a single pager in your kits, and to the extent that we had them, the PowerPoint presentations we received in advance. And if you go to our website at allhealth.org, all of that is online and you can share it with your colleagues. As a matter of fact, I think one of the items that we didn't get updated before we had to come on over was the selected expert list, and you'll find that on our website. There'll be a video recording available in the next couple of days, a transcript also a couple of days after that at allhealth.org. And we commend that to you. There is a green question card you can use to ask a question. Once we get to that part of the program, there's a blue evaluation form, which I plead with you to prepare to fill out and hand in so that we can improve these briefings for your best use. And if you're watching on C-SPAN, you can find all of that background information, including speaker bios and the slides that they'll be using at the Alliance website, allhealth.org. These aforementioned experts are indeed a very good program for your use. They're going to detail the trends in the composition of provider networks and explore the cost, access, and quality trade-offs that we've been talking about. We've had an active weekend at the Alliance as we found out that 2 of our scheduled speakers, Colin Drozdowski of WellPoint and Jolie Matthews of the National Association of Insurance Commissioners, were going to be unable to join us today, but we're pleased to have excellent last-minute substitutes. And before I introduce this shiny new lineup of panelists, let me first add a word of thanks to the Alliance staff, particularly Marilyn Serafini, but also Dexter Williams, and our fine summer interns, Joel Cohen and Bijan Mariar, for their nimble work over the last 24 hours to allow us to proceed more or less smoothly this morning. So let me give you the merest of introductions to this new lineup. Let me do it all at once to keep from destroying the continuity once we get started. We're going to have as our leadoff Daniel Durham. He's the Executive Vice President for Policy and Regulatory Affairs for America's Health Insurance Plans, AHIP, where he's in charge of healthcare reform implementation efforts and policy activities. And we've asked Dan to describe what narrow networks are, what factors AHIP's members use when putting them together and operating them, and what some of the challenges are in doing that. Actually, we're not going to have him first, but he's worth waiting for. And as consolation for having to wait for him, you're going to hear from Paul Ginsberg leading off, who's one of the country's noted health economists. He occupies the Norman Topping Chair at the Schaefer Center for Health Policy and Economics at the University of Southern California. And we've asked Paul to address the implications of this trend for healthcare costs and quality and consumer involvement. Then following Dan, we're going to turn to Katherine Arbuckle, who is Senior Vice President and Chief Financial Officer of Ascension Health, the largest nonprofit healthcare system in America. And Katherine's going to discuss Ascension's experiences across the country. It has 70 plus hospitals or so and other facilities that participate in some networks and not in others. So that will be an interesting real life experience. And finally, we'll hear from Brian Webb, who is the Manager for Health, Legislation, and Policy at the National Association of Insurance Commissioners, NAIC. Brian's going to talk about how insurance commissioners are examining and acting on this trend, and perhaps also describe some of the considerations involved in the model regulations that NAIC is in the middle of crafting. So let's get right to it. We're going to start with Paul, and we're very happy to have you with us.
Thank you very much. Okay. I think I better do that.
Try that. Just about.
Okay, yeah, got it. Well, thank you. I'm really pleased to be here because I always enjoy speaking at Alliance for Health Reform events. And so today I'm going to talk about I've been using the term limited networks. It's, I think, less value charged. And really about why we have these plans have really been around for a long time, but with the development of the public exchanges became far more prominent and just put the issue on the radar screen of a lot more policymakers. And I want to start being the economist, saying that limited networks do have the potential to substantially lower costs. Basically, they do this. The beginning is identifying which providers are lower cost or higher value. And insurers in developing these networks do have the opportunity to use broader measures of costs than just unit prices. And one of the ironic things is that some of the measurement of providers to assess who to invite into a limited network are very parallel to some of the payment reforms that you've heard about, like episode bundling, patient-centered medical homes, and the like. So quietly, they're moving in the same direction. So where do the savings come from? The savings come from steering volume to lower cost providers, and that's a direct thing. In addition, if you're successfully steering patients or have a good prospect of it, you can negotiate lower unit prices with some of the providers in a market. When enough plans do this in a market and enough people are involved, this will strengthen provider incentives to lower costs. Limited networks can also support integration in delivery, and this is fairly new. If we're going to have provider-led plans playing a bigger role, whether the provider is the insurer or in partnership with an insurer, limited networks are critical to their being viable because it's really important to steer enrollees to the delivery systems providers. This approach, through our work at the Center for Studying Health System Change since the mid-90s, we saw provider-led plans develop in the mid-1990s, and the whole purpose was the expectation that they could offer plans with networks limited to the systems providers. And these were abandoned for the most part when limited networks disappeared back then. I want to briefly mention the highlights of the McKinsey work about the experience in public exchanges. And they estimated that narrow network plans were available to 92% of consumers using the exchanges, and that broad network plans were available to 90%. That narrow network plans accounted for 48% of the offerings and 60% in metropolitan areas. And the key thing was that broad network offerings had premium increases 13 to 17% greater than the narrow network offerings. So what's behind the rapid growth in limited networks? Well, I think a big basic reason is that health spending now is increasingly higher in relation to income. So, and we all know about that's from advancing technology and higher unit prices. And it's led to a situation where broad provider choice is a luxury that fewer people can afford. But the key break with the past really was the development of public and private health insurance exchanges. And I would say that there are two key things. One is that the freedom from one-size-fits-all requirements. If you're an employer and you're offering your employees a plan, there's a strong pressure to make it a plan that almost everybody's going to find attractive. That's not the environment to offer a limited network plan is. But with exchanges, you're freed from that because there are a lot of competitors in most exchanges, and a plan can be very successful on an exchange if it appeals to just half or even less of the population. This would be a disaster in employer-based coverage unless that employer was offering wide variety. The other aspect is the fact that the subsidies to consumers are fixed. They're based on the second lowest silver plan premium in a marketplace in the Affordable Care Act or in private exchanges. They're also fixed. So it means that consumers are spending their own money for the marginal cost of a more expensive plan. Okay, now to do this, some basic tasks need to be done well, and they haven't always been done well over the past year, or this year to date. One is accurate and accessible consumer information on the network status of providers. And there are roles for both plans and exchanges. And I'm often, surprised that we don't see more products on exchanges like what the Federal Employees Health Benefits Plan uses. It's a tool from Consumer Checkbook where people click on a plan, they put the names of their providers in, and they see which plans those providers are in the network of. There's a need to monitor the network provider capacity. There's the possibility that a lot of plans have the same providers in the network, and those providers are overwhelmed. This will straighten out over time, I'm sure. And also there needs to be recognition of some of the subspecialties and the attention to physicians' hospital admitting privileges. In specialties like ophthalmology and orthopedics, I think they're pretty specialized, and someone who has a problem with a retina or a problem with their foot probably doesn't want to just go to any old ophthalmologist or orthopedist. There needs to be a speedy exceptions mechanism to allow a patient with highly specialized needs to meet them at network pricing. And also something that perhaps a responsibility of exchanges is ensuring that broad network plans are also available. Now, just a few comments on regulation of network adequacy. There clearly is a need for regulation, but there's a very high cost if the regulation goes too far. I think the key needs are basically the transparency needs and the basic tasks I mentioned. Also a need to prevent risk selection strategies based on poor coverage of some specialties, and a consumer protection needs, which I would describe as basically, if there are some networks that very few informed consumers would find acceptable, it's probably best that they shouldn't be on the market. I think some of the dangers is disarming the most powerful market tool that's available to address the effects of increasing provider leverage in negotiating with insurers. You know, prices have been going up rapidly. They're explain most of the rise in spending. So, you know, the success with limited network plans is going to be important for health spending, especially for lower income consumers. And also I'm concerned about interfering with some of the steps towards clinical integration. Let me just talk about the politics. It's inevitable that pressure from providers to be included in narrow networks will happen. We've seen it now, particularly from pediatric hospitals, being particularly outspoken. And we've had any willing provider laws in a number of states that actually have been around since the 1980s, which seems to be a particularly misguided response to this issue. But in contrast to the 1990s, consumers see much more of a stake of having lower cost products available as a choice. Federal government also has a stake in how high silver plan premiums are, and I'm suspecting that we'll have a much more nuanced reaction to these issues. Thank you.
There we go. Well, good afternoon, everyone. It's a pleasure to be with you today. I plan to briefly cover 5 topics in my presentation. I'll start with some of the latest consumer satisfaction polling, and then I'll turn to how networks are focused on delivering value to consumers, and then a little bit about the importance of increased choice and how those choices enhance the value proposition. And then a little bit about how networks are built based on a recent study that we commissioned by Milliman. And then finally, I'll wrap it up with our commitment to consumers, which really focuses on accessibility. The Commonwealth Fund recently examined attitudes about satisfaction of coverage in exchanges and found that nearly 3 out of 4 are satisfied. This is consistent with a recent Morning Consult poll that showed that 74% are satisfied with their health plan. And directionally, this matches with what we have seen in private polling, showing that more than 9 out of 10 registered voters are satisfied with their private health insurance coverage. Consumers' preferences for balancing provider access with cost is another very important consideration. A recent poll indicated that 57% of small employers would choose a smaller provider network if it resulted in a 5% reduction in their premium. And this increased to 82% if the result were a 20% reduction in premium. And another Morning Consult poll of consumers showed a similar preference, with 58% preferring a less expensive plan with a limited network of doctors and hospitals. Well, health plans are focused on value by finding the right balance for consumers between quality, affordability, and choice. Plans are constructed on the premise of ensuring the highest quality at the lowest price to deliver that value to consumers. The Milliman report I mentioned finds that high-value provider networks allow for more affordable coverage options with 5 to 20% lower premiums compared to broader network plans, while placing an emphasis on quality and effectiveness of providers. The McKinsey report found similar results. Many consumers are looking for this type of balance that delivers value, affordability, and choice. Regarding choice, the recent McKinsey report that Paul summarized in his presentation shows that consumers now have expanded choice of network offerings on the exchanges. Broad networks are available to close to 90% of the population. Narrow networks are available to 92%. This increased prevalence of narrow networks gives consumers a wider range of value proposition and prices among health plans. Importantly, McKinsey found that there is no meaningful performance difference between broad and narrow exchange networks based on CMS hospital metrics. The Milliman report explains in some detail that high-value provider networks are specifically geared toward providing personal and comprehensive care to patients in an environment where providers effectively communicate and coordinate with each other regarding the best treatment for patients. High-value networks are developed through a deliberative evolution process with providers that consider more than just fee levels. Active cooperation and collaboration between health plans and participating providers is really the hallmark of success for high-value networks. Performance on quality measures is the key part of the criteria used for provider selection and inclusion in a plan's network. In addition, health plans must meet robust standards for network adequacy and access to care. Professional accrediting organizations like NCUA and URAC require plans to meet standards for access and availability of service and measure themselves against these standards on an annual basis. State and federal network adequacy laws ensure that consumers have access to a sufficient number and type of physicians and hospitals and health plan provider networks. Importantly, network development is now occurring in a reform market where health plans have new requirements that restrict their ability to vary plan design and control costs, including essential health benefits, preventive coverage requirements, limits on cost sharing, and restrictions on age rating. Variation in network design is one of the few tools for health plans to keep costs low for consumers while ensuring quality. I think I'm missing a slide. There we go. We'll try to go backwards. No? There we go.
Bingo.
Sorry for the delay. So here's our commitment to consumers. This is an important slide, so I'll spend a little time on this. Our healthcare system is in a period of significant change, which means now, more than ever, patients are looking for value and stability in their coverage. Understanding this, health plans' top priority is to provide consumers with the information they need to navigate the new system and to make the decisions that are right for them. One important step health plans are taking is to improve transparency. I know Paul talked a lot about this. While the use of provider networks has been a key tool in delivering value by preserving benefits, mitigating the impact of rising costs, and promoting quality of care, consumers may not be aware of the critical role networks play, how they work, or understand which providers are in their networks. Consumers should have the information they need to make the right choices for themselves and their families. And that is why health plans support ensuring greater transparency of network design by providing accessible, understandable, and up-to-date information about which providers are in a network and timely notice to consumers when providers leave the network. Providing a summary of information about how plans put together their tailored networks to balance cost, quality, and access considerations. Providing information on how consumers can appeal plan decisions, submit complaints, or obtain referrals to out-of-network care when necessary. And we also support continuity of care for a minimum of 30 days for individuals undergoing an active course of treatment for conditions that require more complex care, for serious terminal illnesses, and for mental health. So that wraps up my presentation. Thank you, and I look forward to our discussion.
All right, thanks very much, Dan. And we'll turn now to Katherine Arbuckle from Ascension.
Thank you, Ed. Thank everyone in the room. Oh,
Better get
I
close.
better get some volume here. Hello?
Press it and then wait a couple of seconds. That'll do it. That'll do it. They're temperamental.
Okay. Very good. Well, thank you all, everyone in the room, for allowing me on behalf of Ascension Health to have this opportunity to have this important discussion with you today. Just a little background. Ascension Health is, as Ed mentioned, the U.S.'s largest Catholic health system, as well as the largest not-for-profit health system. We have more than 1,900 sites of care in 23 states and the District of Columbia. And all the health systems that are sponsored by Ascension Health have considered participating in insurance products offered on the exchanges. However, these participation decisions are made at the local community level. And as a result, we have experience pretty much on all sides of the issue. In some communities, we're the named providers in the narrow networks and named in all of the narrow networks offered. In other markets, we are included in some narrow networks, but excluded from others. In some markets, we offer our own offering as a narrow network plan of our own. And then finally, we participate in the non-narrow market, the broad offerings has been described, with other providers in those markets. And I would generalize that overall in most of our markets, we're in some form of exchange product, because generally it fits with our mission to serve the low income and the vulnerable, since that's who's accessing these products on the exchange. So I do want to comment about these narrow networks and then how they can benefit payers, patients, and providers. And we do believe there is benefit in narrow networks, and it can be done through the offering of what we call clinically integrated care. And that's especially helpful for those with chronic diseases. And so some of these benefits that you can outline when you have this tighter integration is that providers can communicate more openly and easily, sharing information between them about patients. And that's especially important and helpful with electronic health platforms when the providers are on the same platform. This can reduce duplicate testing and even conflicting treatment. Payers and providers can share more meaningful healthcare data, work together on healthcare analytics to determine what is the right improvement we can make to quality and cost. The providers within a clinically integrated network can be more familiar with each other's, not just their medical practice protocols, but their administrative practices, allowing handoffs to be much smoother with less error. And then also these tighter relationships allow these providers to comment with the payers back to them where there are service needs and things that need to be improved. So I'll go on to what we also want to talk about, though, and that is there needs to be adequate consumer protection and education, especially for these families who are accessing these products offered through the exchanges. According to HHS, 85% of individuals that are purchasing products on the exchanges qualify for an insurance subsidy. So I think, therefore, we can conclude a couple things. One, they tend to be at the lower end of the income scale. And two, a good number of them did not have insurance previously. In fact, one study we've seen, 57% did not have insurance before. So I'm glad we're talking about this question today. So starting with consumer protection and education, we've invested as Ascension Health in 200 individuals to become certified application counselors. They've received federal training, and they are there to help patients access the networks and understand the website healthcare.gov. But what we've learned is this counseling takes a lot of time, not just for those patients who arrive asking for this counseling and this help, but many times when they arrive with the need of medical care. And that's hardly the time to learn that's when your provider of choice is not in your network. This leads to confusion, it leads to frustration, and sometimes anger. And I will tell you in one example, in Wisconsin, a patient arrived at our emergency room in critical condition and needing immediate intensive care. And unfortunately, he had just signed up with a health plan that did not include us in his network. We admitted the patient because that's what the patient and the family wanted. But neither the family nor us knew what that patient's liability or financial obligation would be for that bill when it was completed. But we were fairly confident as Ascension Health, knowing we had admitted that if this patient is lower income, which likely they are, they will qualify for charity and will be left with the uncompensated care, again, because of the confusion of which providers in the network. So it's obviously important for patients and families to understand their networks when they sign up for the plans. They need to know they may face higher deductibles, higher co-pays, and co-insurance, and possibly their provider's not covered at all. We would advocate to you today that the insurers need to be more accountable on educating their customers on their products. That includes Ascension when we offer a product on the exchange. The education should focus not just on networks and who's in the networks, but education on the related deductibles, co-pays, co-insurance, and even education on trade-offs to be made when choosing a low coverage, low premium product versus a higher coverage, higher premium product. And this is especially important with these folks who do not have experience with insurance and have cultural and language barriers as well. We've found that the online directories are often incomplete, they're outdated, sometimes inaccurate information. Hard copies are not existent. It's also not unusual in a community for several practices or providers to have very similar names, and that can add to confusion. And finally, the access hours and the capacity for those new patients to access those providers is also important. When an individual's enrolling on healthcare.gov, they have to leave that website and go to the various insurers' websites to determine more about providers. And of course, we believe that information should be accessible through the healthcare.gov website. So I want to move on to the quality standards. Ascension Health has been a leader in patient safety over the past decade. We're very proud of our quality record. Our work in the last decade on pressure ulcers has resulted in our pressure ulcer rate being 94% below national norms. Our system-wide work in birth trauma has made Ascension hospitals among the safest places to deliver a baby. We believe we should streamline the existing web of quality programs into an outcomes-based, uniform national core measurement set used by both public and private sectors. Ascension Health and America's Health Insurance Plan, AHIP, made this recommendation last spring in a document that was published called Partnership for Sustainable Healthcare. A defined set of outcome-based measurements can provide the consumers with more understandable and meaningful information to be able to compare providers within their communities. Current practice allows an insurance to develop their own quality metrics of their choosing. Sometimes these measures are similar or the same as Medicare, but not always. And a recent Milliman study released by AHIP, which I believe is in your packets, found that the primary measure used in evaluating narrow network providers are quality measures. And the study goes on to describe how those quality measures can be used. There are 7 different types described in the document, and each has dozens or even hundreds of different measures and metrics. I can tell you in one of our health systems, they're evaluated by 3 insurance plans, same services. One grades them as a 3-star, another as a 4-star, and another as a 5-star, even though it's all reportedly based on the same metrics. And that causes us back and forth with the insurers to sort out, is it the patient population that was looked at? Is it the time period? What are these differences and what's driving them? And while we have a hard time figuring it out, it's much more difficult for physicians to understand how they've been graded as far as quality. And frankly, it's a mystery for patients. So considering there should be uniform, helpful, quality information as part of the patient's decision on these networks. So what is a sufficient number of providers and services to include a narrow network? I understand the work is in progress and it will continue to evolve, and I'm glad HHS and NAIC are working to further define this definition. But I will want to point out just a couple things. First of all, the individual marketplace includes many, many low-income families who are also medically vulnerable. So measuring the distance to providers is sometimes not simplistically solved by measuring miles. 10 miles away to a hospital may not seem very far, but if you have no transportation and you rely solely on public transportation, that can be 100 miles to you. And also, we have folks that are buying on the exchanges that have complex childcare needs. They need flexible work hours, and so their information regarding providers' accessibility within hours, after hours, et cetera, is also important. We've seen a few holes in the coverage in some of the narrow networks. For example, in one market where we are the named narrow provider, we found one of the narrow networks had no access to PET scans. Another glitch we found was that as their narrow exclusive network provider, they had not contracted with any other outpatient lab services or radiation therapy. And we can provide those services, are happy to provide them, but frankly, getting outpatient lab testing at your hospital may not be as convenient as some of the outpatient labs that are available with better parking and better hours. So finally, I'd like to emphasize the reality of the marketplace is still that price dominates. Premiums are what consumers are the most likely to look at when they choose their networks. The Accountable Care Act established affordability standards for health premiums, but its cost-sharing subsidies for those with this low income still leave large out-of-pocket medical expenses that can be unaffordable in this population. Most households with income below 400% of the federal poverty limit have negative net assets. So as a result, even modest out-of-pocket costs create affordability problems. And I will give you one example. This is from one of our markets that's worked with some folks, a married couple, both aged 59, with income of $48,000 a year. They chose a bronze plan. Their premium is subsidized. They pay $3,600 in annual premium. They have a $3,600 deductible, and they're subject to a $12,000 potential out-of-pocket maximum. Working through the numbers, if one of this couple needed a joint replacement, let's say a knee or a hip, their share of this procedure, including the procedures, the premiums, the deductibles, et cetera, would result in an annual expense of roughly $16,000, which is now 34% of their total income. So these high deductible plans, not only are they unaffordable, but they lead to poor care. Coordinating care for this population is difficult. It's well documented that when people will delay seeking their care, or they'll have difficulty adhering to their treatment plans when they're faced with large out-of-pocket costs. So moving forward, it's tempting to develop policies based on anecdotal information. But the reality is we need more rigorous information. We need to know what is working, what's not working around the nation. What works in one community may not work in another community. The one priority we have for the initial attention in this area is education, providing clarity and transparency for the consumer so that they know which and who providers are in their network, how available those providers will be to them, how much cost sharing they'll be accountable for, and the quality that can be provided by those providers. And at the same time, as this more rigorous information is developed, we believe it's more important also to remain flexible and to respond to any particular egregious situation that may come up, which is what we've done in our healthcare system as we see these specific examples come up, responding with compassion to understand what the patient's needs are and meeting that as best we can. Thank you.
Right. Thanks, Catherine. Let's turn to Brian. Brian Webb from NAIC.
Thank you very much. Good afternoon, everybody. My name is Brian Webb. I'm with the National Association of Insurance Commissioners. We represent the commissioners from the 50 states, Washington, D.C., which just became more important to some people in the room last year, and also the 5 U.S. territories, which was clarified last week, are not states for Title I of the Affordable Care Act. One of our jobs is to develop model laws, rules, and regulations that states can choose to use. We do this through an open process where we bring in stakeholders from all various areas, and we try to develop one. And one of those that we have is the Network Adequacy Model Act, number 74, if you're keeping track at home. Number 74 basically was developed in 1996, and looking around the room, looks like about half of you were in kindergarten. So it was a long time ago. And now we are starting to look at it once again to see if it needs to be updated given the new environment. Looking at the existing model, the basic focus was to make sure that carriers, when they set up their networks for managed care, do set them up in a way that there's reasonable assurance that somebody can get to an in-network provider in sufficient numbers and types in a reasonable amount of time. And we leave it up to the carriers for the most part to determine kind of how they're going to set those up. But then states can look at the networks to make sure that that definition of reasonable is reasonable. That when you look at the time it takes people to get to them, any waiting periods, any distance issues, that you make sure that everybody can get to somebody in a sufficient way. And if not, what the model does is if there is an insufficient network, that the carrier makes sure the person can go to another doctor, another hospital, another provider, and that they would be not charged more for going to them. So there is an alternative mechanism set up. And to regulate it, what they do is they require the carriers to file an access plan with the commissioner prior to offering the new managed care plan. And what goes into that is, of course, a description of the network. They need to also say how they're going to monitor that network on an ongoing basis, what the grievance procedures are going to be if somebody has a problem or a question about the network. Notification, how they're going to notify the consumer if there's a change in that network. Either the provider decides to cancel or they are terminated by the company. And also, and this is very critical, the continuity of care. So if somebody is dropped, how are you going to make sure that person continues to get the care they need, either from that provider at no additional cost or through a separate provider? It also goes into the contracts. You want to make sure the contracts that are being set up are not done in a discriminatory way. You're not only with certain kinds of providers so that certain consumers can't get their care. You want to make sure they're not basically giving inducements to providers to make sure they're not providing certain medically necessary care, or there's some kind of gag rules. They can't discuss certain kinds of care. So all those are all rolled together into our Model Act. About 10 states have taken and adopted our model verbatim, taking it just as it is. Another 10 have some kind of similar, and I'll just want to point out, even beyond those 20, states through guidance and through other regulatory have adopted these concepts. They work with the carriers. The carriers do use a lot of these standards in developing their networks. If you want a copy of it, you can go to the NAIC model, go to store, and go to free. There's a whole section of free materials you can get, including all of our models. We also have a white paper that we did on this going back a couple of years. You can get that as well, which kind of looks at the issues that we are now going to be looking at as we look to revise our model. We have set up a subgroup, which is currently doing regular phone calls. They are open phone calls. Anybody in this room can sit in them if you have nothing else better to do with your life. I always picture a 4-year-old man in his mother's basement, but I don't know why. But just sitting down there, calling in, and you can do that. You can provide comments. Anybody and everybody can provide comments, suggested changes, however you want to do it. And we've gone through a series of calls now where we've had all the stakeholders, the carriers, providers, who else? Consumers, of course, others that have come in and brought us their ideas. And we're going to soon start the process of updating it. And there are a couple of areas we are clear we need to update. One is the concept of an essential community provider. That's not something that we were really looking at before. Are those now included in your networks? There's also just issues in the new environment of, are we applying it to all manner of managed care. Some states only did what you would call your old managed care, closed network type of plans. Now do you go out to PPOs? Do you go out to others as well to make sure everybody is doing what they need to do? We're having weekly calls. In fact, our next one is Thursday, July 24th at 1:30 p.m. Mark it on your calendars. Be there as we start looking at amendments. We've received comments from about 30 different groups so far, and we're going to start going through those and seeing where we need to update our model. If you want information, the website is there. You can go and get the exact call-in information. What are the issues? One is just the flexibility to reflect state needs. This is always going to be our number one point. We don't want a one-size-fits-all. Federal government comes in and says, this is exactly the time and distance for each type of provider. We don't think that will work. I don't know about you, but Wyoming is just a tad different than Los Angeles. So what are the standards? How do people get there? And there were some good examples brought up as well. What about certain populations in certain maybe very populous areas, but maybe some transportation issues? And states have been looking at these issues and are best to address these issues given on their needs. But then we do, as has been brought up, we need a balance. There's no sense in going here and saying, we need to get rid of all of these. No narrow networks, because we need to balance quality, we need to balance affordability, and then we need to balance access. And how do you do that, and how you do that in a model and make sure everybody is protected is our number one concern. Some of the key issues we're going to be looking at: tiered networks and narrow networks. Tiered networks are basically, if you go to this group, you have to pay this much. If you go to this group, this much, this group, that much. And they're tiered up, especially in formularies, which we're looking at more and more now than we have in the past for prescription drugs. How are those set up? Narrow networks. One issue in particular we're going to be looking at is in a couple of states, carriers said if you purchase in the state, we will cover you either as in-network or out-of-network. But if you go to any provider outside the state, we will pay nothing. It's not even like a higher cost sharing. It's just we will pay nothing not covered. We're going to have to look at that. We're also going to have to look at provider directories and updates, and I think that was already addressed here, and this is probably the most critical issue. You can't have a free market when people cannot get access to information. We had that this year. I'm not placing blame on anybody. It was a rough year, just trying to get plans on, getting things up and running, and get it out there, but we've got to do better in 2015 open enrollment period. Consumers need to know that if they purchase that plan, is their provider in the network or not? They have to have clear access to the website to make sure they can know which ones are in and which ones out. And tell you the truth, providers do too. I had so many provider groups calling us and saying, I had no idea. I got the call from the consumer. They were doing their due diligence. I said I'm in. I have a contract with that company. Then I find out I don't have a contract for that particular plan. So we need to make sure everybody has the information they need, and if there are updates, that those notifications are going out so the consumer is well aware of what their options are. And we do want options. There are many plans, and we're going to have more plans on the exchanges next year across the country. Are some of them narrow? Some of them not narrow? And do people know the difference, and do they have the options available to them? So the directories, are they accurate? Updates accurate? Consumer information, education, do they have the right choices before them? And then another issue we're going to be looking at is the surprise bills. How many like surprises? Well, I like surprises, but not when it's a bill. And this is where you go into for a procedure. Your doctor is in the network, your hospital's in the network, and your anesthesiologist is not. That's called surprise. You're going to be charged higher for that, and making sure everybody's educated. States have been doing things on this. Federal government's even looked at this. It's something we're going to be looking at to see if we can make sure, again, everybody's educated. It's okay if he's not or she's not. What's not okay is nobody knows. And then really no choice was given. And I'll leave you with this last slide. If you have any questions, please call Jolie. She was supposed to be here, and I ain't taking the questions. So if you have any questions, she is the staffer in charge. She's the one writing and updating the model. If you do have any questions, please call her. She'd be able to help you out. And if you are interested in this, please join the calls. We hope to be done by November of this year with a brand new model that states can use to update their procedures. And if you want to be part of that or just want to know what's going on, jump on the calls. We'd love to have you. Thanks.
Terrific. Thank you so much, Brian. Brian has agreed in the course of the Q&A session to channel his inner Jolie. So you now have a chance to join the conversation. And I'm going to exercise a little bit of prerogative just to clarify some things. At the appropriate time, you can fill out a question card that's in your packet. You can also repair to one of the microphones that are in the room, and you can tweet a question using the hashtag network adequacy. So you've got all sorts of channels. And the first thing I want to do is a sort of a factual clarification. We've heard a lot of talk about in-network and out-of-network. How many people don't know the difference between in-network and out-network for purposes of this discussion? We've got a very sophisticated audience here. So the question is there a typical pricing pattern? In other words, what's the penalty? Maybe not out of state being zero, but in a typical plan, if you are in a narrow network and have to go out for some reason, or think you do, is there a substantial differential, or is it fairly nominal? So how important is this, is what I'm asking. Dan, you have any sense of that?
Sure. Again, I think it's critical from the point of view of providing value to consumers that we allow these high-value networks to be a choice. As many of you heard from a number of the speakers today, many consumers are buying based on premiums. And to get that premium point down to an affordable level, plans are offering narrow networks. It's not the only option. You have broad networks, as you can see in the McKinsey poll, available to over 90% of the population. And so it's a choice there. But if you're in a plan that does have a specific network, then there are certain requirements to go outside that network. Plans don't say you can't do that, but they'll work with the individual on their specific needs. So if there's a particular type of specialist that simply is not in the network, then the plan has an obligation to work with that customer to find someone out of network that can provide that medically necessary service.
If I can add something, part of it depends on the type of plan you have. If you are in an HMO that does not have out-of-network coverage, then it's far more restrictive that you won't get anything out of the network than if you're in an HMO with point-of-service coverage or a preferred provider organization. But I would say the differences are substantial. I think they have to be for the narrow network approach to work, because it's not just that you'll pay a higher, say, coinsurance rates with the out-of-network, but that you won't be benefiting from the insurer's negotiating ability to have negotiated a network price, so that you'll be liable for the amount beyond what the insurer allows for out-of-network care, in addition to the extra coinsurance.
And Paul, is it typical that if that happens, whatever the out-of-pocket expense incurred is, doesn't count toward the out-of-pocket limits or the deductible in the plan, or not?
Yes, the coinsurance counts, but not what we call the balance billing.
Okay. Yes, sir, you want to identify yourself?
Sure. My name is Daniel Davis. I'm with the Administration for Community Living in HHS, and one of the considerations that we're looking at quite a bit right now is the access to providers for people with disabilities in narrow networks. Specifically, there are considerations where there's been a number of studies on subspecialties where there's 20 or 40% of providers, according to some secret shopper tests, that in certain subspecialties that don't serve patients with mobility disabilities, and to what extent are NAIC and the private insurance industry, taking that into consideration and making sure that there isn't inadvertent health status discrimination.
Right?
With the NAIC, yes, that is something that has been raised as an issue and something we need to look at, something that state regulators need to look at when they're reviewing the various plans. Not just that, but especially with mental health parity and things coming on and new requirements on behavioral health, et cetera. There's a lot of issues there that we need to make sure that everybody is taking into consideration. So we would agree.
And I'll just add that health plans work very hard to comply with all the federal laws, state laws, rules, and regulations. And they submit their plans for review, and they're approved in the state, and if they're a qualified health plan, also by the federal government, and they're certified. And so they have to meet the standards set in statute and in regulation to be able to compete in the marketplace. And we take that very seriously. And if you don't meet those requirements, then you're not certified to be in the market.
And having the gentleman from the administration asking that question reminds me of a question that was submitted in advance that is related. And it makes reference to the fact that the administration had communicated with plans not so long ago that they were going to focus on areas that have, and the questioner actually quotes, historically raised network adequacy concerns, including, among others, mental health providers. And I wonder if we have any other elaboration of how the current discussions or the current controversies, for that matter, deal with behavioral health issues. Katherine, do you have anything to add on that?
I will just add that clearly that's a consideration. We focus so much on first what are the physicians and the hospitals in those networks, and that becomes the bulk. And as Brian pointed out, then you have the anesthesiologists and behind. My point was there's also outpatient access that needs to be considered, mental health, home health, all of the care continuum for a clinically integrated network to be successful has to be considered, and that entire network has to be considered. I don't have any specific examples for you yet, but I absolutely agree with your point.
Okay. All right, Carolyn?
I'm Dr. Caroline Poplin. I'm a primary care physician. I have two questions for the gentleman from AHIP. One, in the satisfaction surveys that I think you presented, did they break out people with chronic illnesses or people who have had a serious illness in the last year versus healthy people? Because most people are healthy most of the time, and if they don't use their network, they'll be satisfied with it. My second question has to do with choice. It sounds like each insurance company in an exchange will present a variety of plans. I guess maybe they're required to present, bronze, silver, gold, platinum. And the experience with Part D has shown that people get very confused when they have too many choices, when they have five insurance companies offering 50 plans. That's hard to deal with, especially if you have to do it every year. And in Part D, I think there was a study that showed that, in fact, most people didn't change their primary plan. They just kept the same plan year after year, even though it wasn't the best plan for them. So, two questions.
Well, thank you for those. First, on the poll, the Commonwealth Fund survey that I mentioned in my slides was very comprehensive. I don't have the actual sample data in front of me to answer your specific question, but if you go to their website, they provide a very thorough explanation of where their sample was drawn from, so you could find whether or not it covered the specific populations that you mentioned.
Or whether it's separated the specific populations, because you're going to get a different answer from people who have to use the plan versus people who just think it's going to be great because they don't really know. They've never had to use it.
Right, and that survey also included those that actually have used their plan too, and there's data on that as well. So again, I encourage you to go to their website and pull up their survey. It is very comprehensive and very, very informative. With regard to your second question, if you could repeat that for me.
Choice. Do you worry about the fact that people are going to get confused by having too many choices? And
depends
each
on-
one has a lot of information. The Part D experience hasn't been all that reassuring on the question of whether people can make a good choice.
Now, that's a very good question. It really depends on the individual. Some are very savvy and sophisticated about, looking through the websites and finding what's best for them. Others need a lot of help, and that's why the ACA provides for navigators, assisters, we have brokers as well, and others that can help the individual review plans and make the choice that's best for them and their families. But and health plans are doing a lot too in terms of basic education and putting as much information as they can on their websites to help individuals make the best choice, including things like cost calculators. So you know you're going to have a specific procedure, what your out-of-pocket cost would be for that and the like.
Yeah, if I could add something to proliferation of choices, I think the structure of the offerings by being grouped into tiers defined by actuarial value probably helps consumers a lot going through this, because I suspect that most consumers first decide what tier, what metal they want to get, and then so the numbers of plans aren't as great.
Thank you.
Go ahead.
No.
No, I actually wanted to follow up just a little bit, because one of the questions that has been raised, at least in the materials that our staff has assembled, is the question of how a consumer, in trying to make the choice, can distinguish between a narrow network and a broader one. And presumably those aren't two different things. There is a blend, there is a range of narrowness, if you will. Are there some standard formulations that are being used either on the marketplace websites or among the plans that can help people who don't deal with this kind of terminology every day to understand which of the choices they're making along that spectrum?
I can
Paul?
answer that. Well, in reading the McKinsey study, I'm presuming that there is nothing out there like, as you were saying, Ed, but since they came up with their own definitions of whether it was very ultra narrow or just narrow, and it was purely based on what proportion of the hospitals were in the network. And I probably would be a good idea going forward, in the same way that we have 4 metal tiers of plans, to also, they'll be arbitrary, but say that, a plan which has below a certain threshold of providers is called a narrow network plan. And, consumers, so in a sense, consumers can put some aside, and then, there won't be standardization like actuarial values, but at least it would help the consumer simplify their search.
Brian, any talk of something like that in the revisions that the NAIC group is considering?
No, not at this time. As far as in our model, it is something that, as far as choices and information, I think states would like to look at. I mean, we don't, in the past, have seen carriers really try to hide things like that. They want the information, they want to distinguish between one plan and the other. So how that's done and how clear it is, we'll work toward that. It's probably not something that can be in our model specifically, though, trying to standardize it anyway.
And I'll just add that plans do provide a summary of benefit and coverage on healthcare.gov, and so that provides important information to shop around. There's other information on healthcare.gov. New information will be coming in the future, specifically with regard to quality and consumer satisfaction. They're currently building that in and working to produce that. So, I think just with Part D, it'll take a while for the website, healthcare.gov, to get where it needs to be to provide all the information that consumers want. But you have to walk before you can run. So we're still in the first year, and I think we find from the experience in state-based exchanges, those states that try to do too much on their websites ran into some real challenges. And, lesson learned there, but health plans are committed to providing the necessary information so consumers can make the best choice for their families.
Okay, yes, ma'am.
Hi, Lauren Kennedy with the National Partnership for Women and Families, and my question follows nicely your last comments, which is, I was wondering if any of the panelists could speak to what have been successful strategies for ensuring consumer access to this type of information, specifically with regard to quality and performance data. I think it was in everybody's sort of presentation that this is a key criteria, not just for provider selection, performance on quality and value metrics, but also the consumer's ability to access that information, understand it, and use it to make informed choices. And specifically with regards to exchanges, how do we support consumer access not just to plan performance on quality metrics, so being able to rate plans by quality data, but also consumer access to how providers themselves are performing on quality metrics? I think we would make the case that if we're looking at narrowed choice through narrowed networks or high-valued networks, however they're referred to, that consumers have a distinct interest in understanding how individual providers in the network or facilities are performing on quality metrics in a way that's consumer-friendly and understandable to them.
No one disagrees, apparently.
No one disagrees.
Oh, well, it's not an argument. I was wondering if you're able to share some strategies that you've seen successful or that you might be sort of contemplating, or policy changes that might be necessary in order to sort of compel this type of consumer access to provider and facility level
And can
performance
you
data.
can you do it directly, or do you have to do it by, in effect, requiring the plans to collect the information in some way?
Yeah, well, I think this is a direction we want to go. And I think the first thing is to get more meaningful quality data on providers. And, I did notice that two of our panelists' organizations together were, promoting the idea of standardizing quality measurements. And I think that as we get better at measuring quality, and as we get some consistency, then it's going to be far more possible for plans to really advertise or inform about the quality of the providers in their network. Because ultimately, as you said, I think what matters most to many people is the quality of the providers.
Paul, is it a fair assessment of the state of the art that the people who measure quality aren't very happy with the state of quality measurement at this point?
Yes. I think there's a consensus on the direction of, getting rid of a lot of, the process measures of quality and replacing them, because now we have the ability to do more in the way of outcome measures.
Catherine?
I do believe we would advocate for collaboration and to make it more universal, as I stated earlier, that having so many different ways of measuring quality, and that's where we are today in our healthcare delivery, but with so many different ways, you get completely contradictory conclusions. You read magazine coverages of who's the best hospitals, and they're in, they're out, and you don't get any real conclusion as to who's providing the best quality. So I think this area has to be improved, needs to be universal, and we advocate working with insurers, employers, and patients to come up with the right quality metrics.
Can I ask just one follow-up? Do you feel that that's best done in the private sector, in the public sector, or in sort of collaboration with both, if we're sort of aiming towards better alignment and standardization?
Well, with as far as we have to go, it's certainly going to start in multiple areas, public and private. I think our point is that the ultimate goal would be single. It should be something universal that we're all accustomed to and understand. I think in the interim, though, we'll work with insurers, we'll work with HHS. We're interested in pursuing this to help not narrow the number of quality indicators, but make them more understandable and comprehensive.
Let me just digress for 30 seconds and tell you that Jim Talon, who is on the Alliance board and who runs the United Hospital Fund of New York City, once observed that because of all these various rating systems, New York City contained 40 of the top 25 hospitals in the United States.
That's right.
Yes, Gary.
Stuart Gordon with the National Association of State Mental Health Program Directors. In the mental health field, a lot of services are provided through peer support, both in mental health and in substance use. Brian's, and in an aligned area, I know a lot of services, despite scope of practice laws in the states, can be provided by nurse practitioners and physician assistants. Is that something, I guess it's two facets of the same issue, is that something that NAIC is looking at in its revised model?
It's not currently on the table as an issue that we're going to be looking at. We've tended in the past not to get much involved in who provides the care and those kind of certifications, but it's something, if it's something you'd like us to look at, you know the number. So, but it's not something in the past we've dealt much with.
And I should say that we've received several questions on cards asking about the role of nurse practitioners and other non-physician providers in these circumstances. And I wonder, are there states that have taken steps to define adequacy to include some of these non-physician providers? Anybody know? There's a crowdsourced question for you. If anybody knows the answer to that question, and we'll send it to us at allhealth.org, we'll put it on the website. Yes,
Hi
right
there.
ahead.
Thank you. My name's Chandler Weiland. I'm a consumer and caregiver. And Katherine, you come across conveying caring for the consumer and yet lamenting that your narrow network lacked an outpatient laboratory, that the narrow network included a hospital laboratory, but it didn't seem easy for the consumer related to parking issues, which I totally understand. But it would seem that they have all of their information, that that little parking ticket can be validated at the lab. So it would not necessitate hiring or contracting with an outside lab. Just a simple thought bubble I had.
And appreciate the thought. And I would, if you allow me just to add, we would be happy to serve all outpatients for their lab testing and make the access into that garage or that parking lot as easy as possible, whether it's getting a ticket validated, but even just getting them from the garage in. You know, if we can give, some folks have trouble walking from that parking lot up to the entry. And I'm saying folks may not want to come to that big hospital campus. They may want to go to the accessible Quest lab that's sitting there, you know, a half a mile from their home.
Most of the parking lots that I've been in for hospitals, they have a button as you enter the parking if you need assistance.
Sure. Oh, sure. And again, we'd be happy to provide that.
Okay, yes, Mary.
Hi, I'm Mary Tierney. I'm a pediatrician, and my background is also that I ran EPSDT in the Office of Child Health for working for a man by the name of Leonard Schaefer. So obviously my question is going to be on pediatrics. What are you doing, what are we really doing for kids that absolutely must have tertiary care, children's hospitals, and so on? I just talked to a man the other day who had, talked to him again, who had a child born with tetralogy of Fallot, very complex heart disease. They wanted to send his child to a surgeon who hadn't done any heart surgery on kids in about 10 years. And we luckily got him into a children's hospital. So how are you addressing these things, especially with kids with very complex needs?
Well, I think that's where choice comes in. And in this current marketplace, there's a lot of choice. You know, whether you want to choose a very broad network or a very narrowed network or something in between. And so it's important that consumers have the right information so they can make the best choice for their families to get the care they need.
Yeah, I have an answer to the question. This sounded like a case of the need for a very speedy appeals process to provide access for very specialized care to those providers who really are experienced in it. In the various work I've done over the years in healthcare markets, one of the observations is that often the pediatric hospitals are by far the highest priced hospitals in the area. So the inclination to create a network without some of them, I can fully understand that. But, if you're going to do that, comes the obligation of providing access for those that cannot be served in the general academic medical centers that are in the network.
I just add consumer education and involvement.
And if I could just add to that, because often the departments of insurance, the commissioners do get involved in these kind of cases. They work very closely with the insurance companies as well as with the consumers to try to make sure if it's determined to be insufficient to just resolve the issue. Instead of just saying, you got to cover everybody, let's deal with it situation by situation. That's why the grievance procedure is there. That's why there is regulation, just to make sure everybody can resolve the issue, and it most often does. So.
Okay. If I can ask you to forbear for just a second, I wanted to follow up on something with a question on a card. And I should say that we have enough cards to carry us through Tuesday of next week. So you might want to use the microphones if you absolutely positively have to get your question answered or at least addressed. This one actually is also, directed to you, Brian. What's the NAIC position, if there is one, on mid-year network removals, as we are seeing with the Medicare Advantage plans? And I want to come back to the Medicare Advantage part, but what happens when you sign up for a plan that has the physician you want, and then she or he drops out halfway through?
And our current model deals with that by making sure everybody's notified of those changes, and then also make sure if there's an issue of continuity of care, that is taken care of. It is something we're looking at, especially since, again, there's been a drastic change in the marketplace, especially the individual market, where we do have a policy year. We really didn't have that before. So we are going year over year, and so we are looking at how that can be resolved if something needs to be done there. We have no position on yet whether it should or shouldn't, but it is something we're looking at given the new environment.
Dan, do you want to comment on that? Is there a general industry practice for that kind of situation?
Well, you mentioned Medicare Advantage, and their plans are under extraordinary pressure. As you know, the ACA reduced payments by over $200 billion over 10 years for MA plans, and the administration has added some additional cost reduction on top of that through the regulatory process. So plans have to find a way to provide value to consumers, and some of that is by taking a closer look at their networks and to see if there are ways that they can tailor their networks to provide more value to consumers. There's been a lot of discussion with the administration in terms of adequate notification to consumers and the like, and we feel that that is important, and we're working towards that goal.
I'm not sure how we get there, but I think to the degree that I believe that limited narrow networks are going to be an important part of the landscape for a long time, we should start thinking about how to move the system so that all network agreements between plans and providers conform to the dates of the plan, so that they were on a calendar year. So then this issue of provider dropping out of the network would be very limited to, a provider that got out of practice or something like that.
And I'll just add, too, which I think is an important part of this debate, there have been numerous studies out there that show tremendous price variation with little or no correlation to quality. And so that is something that we have to take a close look at, and plans are trying to deal with that by saying, well, let's focus on those providers that provide value. Given the tremendous price variation in this country, you can provide good quality service to consumers by finding those providers that provide valuable services, high-quality services at a lower price. And that's the premise behind doing networks in a way that's focused on value. And if we just open it up to everyone, including, then we're stuck back in this fee-for-volume type system, which we all agree we have to move away from. And this is one of the ways that plans are helping to move us towards a value-based system.
Okay. Yes, sir. Thank you for.
That was actually my tweet, and you've answered all of my follow-up questions now, so I'll just sit down.
Let the record show we respond to tweeted questions. Yes, go right ahead.
Sure. My name is Marshall Nannis with Truven Health Analytics. This question's for Brian, but for anybody on the panel who feels like chiming in. Brian, going back a couple questions, when you mentioned stepping in that pediatric example, when a network was determined to be inadequate, what other tools do you have at your disposal when networks are determined to be inadequate? Are there fines on plans that don't offer enough coverage? Are there bans on them offering continuing to sell insurance in a state, or do they just have to sort of promise to get better and to improve the problem?
Well, it depends on the state and whether it's actually in the law, in the regulation, as to what the standards are. They're going to file their plan at the beginning of the year when they're saying we want this plan. They will file their access plan. The state will look at that. If they don't approve it, then they will ask the company to refile it. So you got to get that approved first. But then if during the year there are a lot of grievances and a lot of issues, then of course the state, as the regulator, can step in, can talk to the company, can ask them to make some changes to fix issues, and then you always do a market conduct review. Eventually you could fine them, you could withdraw their license. I mean, you have all of those at your disposal. I mean, we're not going to get there on this kind of issue, but yeah, you talk to the company and usually you can resolve the issue that way. But you have all of that as your background. You're the regulator. You've said that that company can sell that product in that state. If they're not actually fulfilling their access plan, which they filed with you, then you can take action against them to fix it.
Thank you.
Bob?
Bob Griss with the Institute of Social Medicine and Community Health. There are two issues that I haven't heard addressed so far, and yet they're trends, in a sense, in the healthcare marketplace. One of them is concierge medicine. How will this focus on network adequacy deal with doctors who want to collect a special fee just for the privilege of going to them? Secondly, the subject of conscience clauses, since we have a representative of the Catholic hospital systems. When providers choose not to provide certain FDA-approved medical services, what obligations does the health plan or provider have to ensure that that patient is able to get the medically necessary treatment that they want?
I'm not sure that the provider has the sole responsibility here. There is a matter of disclosure up front about what providers are providing what services, and people do sign agreements and waivers, and I may be wrong on this, and I'd be interested in Dan's comment about this, but if you're a plan, presumably you have the responsibility for making sure that the services are available through one or another of the providers.
It really depends on the state. There's a lot of variation in state law on this particular issue.
Well, I'll comment generally that of course, being our mission base, we would not provide ethically, and we follow ethical religious directives. But as patients and families access these plans and are wanting other services, it's expected through the plan to get them the access that they need. So it's determined at the plan level.
So how do you do that if let's say you're a hospital, in fact, let's say you're the only hospital in a geographical area, and a provider, and you decide that something is not consistent with your with the provider's or the owner's religious beliefs, how does the patient get the medically necessary treatment?
I can't comment on all. I can tell you in our markets, we're not the sole provider in our markets.
And I don't want to belabor it, but we are getting a little bit off the question of adequate networks at the plan level, and I want to make sure that we don't miss out on the opportunity to get to these questions. And that means calling on you at the moment.
Thank you. Thank you. My name is Camille Bonta, and I'm with Summit Healthcare Consulting, and I represent a number of provider organizations. Thank you. This has been a really terrific panel discussion. I'm glad the topic of network adequacy has been brought up with respect to Medicare Advantage plans, because I think some of the same issues regarding transparency to patients about who is in their network at any given time due to mid-year contract terminations at no cause are very concerning, and then whether subsequently there is adequate networks of providers. I'll add that Senator Sherrod Brown and Congresswoman DeLauro have introduced legislation pertaining to those mid-year terminations. But on the topic of network adequacy, I know the question was raised of what do you do if you determine that a network is inadequate. But I think also importantly are what are the tools being used to ascertain whether or not a network is adequate. And Mr. Ginsburg, you raised a really important point at the very beginning of this conversation. So and I would welcome a response from either Mr. Durham or Mr. Webb. But if a plan looks at its network and says, well, we have 30 ophthalmologists in our network, and they're looking at the specialty designation, right? But they're not looking at subspecialists for which there may not be a Medicare subspecialty designation. Should they be doing a little bit more of a deeper dive if, for example, someone needs to see a retina specialist, but that ophthalmologist doesn't provide a lot of retina services? Should they be taking it down to the CPT level to find out, do we have an adequate number of retina specialists in our network to be caring for patients with very specific needs? So I think that's a really important point. And I've heard of health plans using the geo-access reports to help determine network adequacy. That does not go down to the subspecialty level. It may just look at the specialty designation. So I'd welcome any thoughts that Mr. Webb or Mr. Durham have on, or even Mr. Ginsburg, on ascertaining whether truly there is network adequacy.
Yes, well, let me just say something quickly about the subspecialties and then move on to the other questions. I would say, we're in a learning process about how to regulate and have transparency for limited network plans because they've just arisen. And I'm familiar with some anecdotes where, say in ophthalmology, which I know fairly well, where the issue about retina specialists was raised, and through the Academy of Ophthalmology, it went to the insurer, who I think just responded. So, oh, we didn't know that, so we will make sure to put some retina specialists in the plan. So I think it's just discovery that this is an issue. And I would say yes, the detail that's going to be needed in some specialties probably will have to go by subspecialty. And it's going to make it more complex, but this is going to be a big part of our market environment, so we might as well just do that.
Anybody else, Brian?
It does vary by state, but some do a deep dive, and they go down to specialists, subspecialists. Not a Medicare Advantage, though. We don't get to regulate that, so we're excluded.
Yes, go right ahead.
My name is Jesse Bushman, and I work with the American College of Nurse Midwives. And I want to give a little bit of information, then ask a question. We've been doing a survey of the plans that offer coverage through the exchanges, calling them and asking them about inclusion of nurse midwives and their services in the plan's provider network. And what we've discovered is that of those that responded to our survey, which is about a third of the plans,
15% of them flat out do not include a nurse midwife in their network at all. About 40% of them do not cover birth centers either. And about 35% of them do not pay the nurse midwives at the same rate that they pay the physician for the same services being provided. And my question is, in their regulations, CMS very carefully stayed away from dictating what types of providers would need to be included in a plan, so that the insurers could have the flexibility to do exactly what we're talking about and maintain lower levels of premiums, and that's understandable. But my question is, in our case, the CNMs are attending 8% of the births that occur in the country, which is fairly significant. And maternity and newborn care is a required part of the Essential Health Benefits package. And so I would look at that, and I think I could argue reasonably that that's a provider type that should be included in a plan's network. And I'm wondering how you make decisions about what types of providers are and are not going to be in your network, and what's the criteria. I think if I was to argue that a plan could include a few family practice docs doing deliveries and therefore did not need to include any OBs, I think probably people would say that was unreasonable. So my question is, where is the line, and how do you decide when is a certain provider type necessary for inclusion in your network?
Is that an NAIC question, Brian?
No, we check to see if all the ones required by law are in there. So that's what we do.
Dan, you're the default second place
Sure.
answerer.
And again, we talked about this previously. To be a qualified health plan, plans have to be certified, and part of that certification process is a review of how they meet the network adequacy standards. And if you don't meet those standards, you're not a qualified health plan to participate on the exchange. And I know CMS is looking at this year. They required health plans to submit a lot more information in terms of who was in their provider networks, the names of the doctors, the hospitals, and the like. And so they have all this data now. The plans have supplied it, so they can do a test using the software that they have to make a determination whether or not they believe the network is adequate based on their standards. And if it's not, then they can work with the plan to get it to a place where it needs to be to get certified. So really depends largely upon the rules and the regulations that are applied to meet certification. But I'd also add that there's a measure of choice here. Some plans go beyond what other plans are doing, and they may have a higher price level because of that. Broader networks, lower out-of-pocket maximums, lower deductibles, but it comes usually with a higher premium, in a platinum plan or a gold plan. So there are trade-offs here that consumers need to look at before buying a plan.
And I'd offer just one follow-up to that, and that is that from an insurer's standpoint, I'm not so much complaining about them as wanting to say that there's this huge opportunity for savings for the insurer to take advantage of, because the practice pattern of the nurse midwife is something that reduces levels of interventions and therefore reduces costs. And so I don't see it so much as a complaint against insurance companies as something that we can do to educate them to say, here's an opportunity for savings, and I think it would result in savings for your members as well.
Well, I agree with you. A lot, too, depends on state laws. I mean, we'd like to see states go to a place where nurse practitioners can practice to the top of their license, and for other providers as well, so we could take advantage of those types of cost savings while preserving quality.
Thank you.
If I can ask you to suspend for just a moment, I wanted to take just a couple of the questions that have come in on cards, which actually dovetails very nicely with a couple of questions that we received in advance. And it has to do with the question of essential community providers. First of all, I want to make sure that everybody knows what an essential community provider is, and so I'd like one of our expert panelists to take a crack at that. But the ACA requires plans to include substantial numbers of them, whatever they are, and they are particularly important to the lower and moderate income folks and isolated populations that Katherine was talking about. How effective is the regulatory device, which I think is a threshold of saying that you need to have 20% of all of the essential community providers with a change pending to raise that to 30%. Is that the appropriate way to assure that folks can provide the provider, that they can find the providers they need?
I mean, as far as the NEIC and our work on the model, we're just going to have to put in what that requirement is. As far as the regulation, we're looking at it, especially when it comes to some of the Native American and Alaska Natives, and what they have to do there, have to at least try to get a contract with them. Whether they can get one or not, it's a question. And there's a lot of things involved in that. I think that's going to have to be something that kind of evolves over time. We have the thresholds in place. Now we're going to have to look at how we can enforce that, what's necessary, and that's something we're looking at with our model, is get the thresholds in there, but then from there, how do we move forward and how do we regulate and make sure that they're contracting with them and reaching out to them, and what those things mean. So it'll take time, but we're working on it.
Katherine?
Yeah, and I couldn't comment on this 20% the right number or 30%. Obviously, it depends on markets, access, et cetera. But I will say that we are supportive of essential provider requirements. You know, given our history and our footprint, we do a lot of work and partner with federally qualified health clinics, as well as we're the safety net provider in many of our communities. Certainly right here in Washington, D.C., we do a lot of work with Unity, the FQHC here. So we are just proponents for making sure that's coverage there to serve the poor and the vulnerable.
And I'll just add, the threshold has increased for 2015. So in 2014, plans participating in the exchange had to include 20% of essential community providers in their area, and now it's 30% for 2015. And so plans are, meeting that regulation. But again, it comes at a trade-off in terms of price. To the extent you continue to expand the network access requirements and health plans, that in turn will lead to higher premiums. So we have to be cognizant of that trade-off as we look to further regulate and restrict plans' ability to provide that kind of high value to consumers.
We have just a few minutes left. We're going to get this question and maybe a couple from cards before we finish, but I'd ask you to fill out the blue evaluation forms while we're finishing up the conversation, so we can get some feedback from you about this program and others that we might do. Yes, sir. Thank you.
Hi, my name is Doug Jacobs. I'm a medical student and also an intern with HHS. And I understand that health insurance companies, they're using value as a way to select physicians. My concern is that they would also exclude physicians who treat sicker patients, because those physicians would be more costly to include in the network. So I was wondering, is this happening? And also if anything's being done to prevent it from happening.
I have seen no evidence of that.
Yeah, I would say that when insurers are trying to look at value, which to me has two dimensions besides price, they're looking at broader measures of costs to see, for an episode of care or for a period of time, which provider is less expensive. And then there's the quality dimension. I would think that insurers would want to adjust for different patient populations, but what they can effectively do is an open question. And so, it's probably not ideal now. Hopefully it'll get better.
And I would just note that in our model, and something states to look for, is that non-discrimination, that you're not contracting with people just because they, or providers because they happen to care for certain types of diseases, certain groups of people. So that is something that we look for, and we'll continue to kind of look at that as we move forward.
Thank you.
I've got a question here, I guess that would go initially anyway to Dan. Providers listed on plan networks may not be accepting new patients. How do plans inform current enrollees and potential enrollees about which providers are truly available?
Well, that's an important question, and that's one thing that plans are committed to provide up-to-date provider networks on their website. But I'll add it's a two-way street. If a provider is no longer taking new patients and they fail to communicate that to the plan, and the plan tries to make it very easy for them to do so through special call-in lines and the like. But part of this rests on the provider to let the plan know when they're no longer taking new patients. So, we have to work on this collaboratively to make sure that consumers have the latest information.
Catherine?
And that's a fair comment. The providers need to be in contact with the plans for sure. I can tell you in our health system, if someone is calling for an appointment and that physician's reached capacity, cannot take the patient, we'll ensure that they get referred to someone who can within the area. But that's our practice. I don't know that that's any regulation or requirement.
I'm sorry, Brian, you want to add anything? If I can go back to the related question of the maybe not completely accurate directories or mid-year cancellations as opposed to physicians who aren't taking new patients, who bears the burden of the lag in information? Is it the patient? Is it the provider? Is it the plan? What happens when that surprise bill shows up? Whose surprise is it?
Well, again, it depends on the circumstance. We think it's important that, for example, hospitals that are in the network of the plan but employ anesthesiologists or pathologists or other specialists in their hospital that are not in the plan, they have a responsibility to notify the patient before they, go under surgery to say, well, this particular anesthesiologist is not participating in the plan that the hospital is, and so it could result in higher out-of-pocket costs. So we think there is some responsibility there on the hospital side in that type of situation.
One thing I can add is that outside of this issue of networks, that a number of states have put restrictions as to how much these out-of-network physicians can charge. Just because these are anesthesiologists and other hospital-based physicians where consumers are just not in a position to be able to make those judgments.
I'd like to add just one comment to this point, and I do believe that, yes, the providers are standing in the relationship with the patient, and as we've done, we're educated, we're working with them to know which providers are in their networks and not. But I do come back to, as the patient or family is signing up for a network, they're entitled to know who's in, who's not, and we do see that education requirement needs to be provided by the plans, and probably something in much more robust than just directories, probably something more like examples, scenarios, things to ask, so that, again, that the patient can be more informed.
Okay, I think that probably is a very good note on which to bring our discussion to a close. We didn't get, I really apologize to those of you who spent the time to write some very good questions on the green cards, but it's a subject that we are not letting go. Obviously, there is a high level of interest in it. There are a lot of complex pieces of it, and so we plan on revisiting this issue in the fall, probably with a briefing, perhaps with a webinar. Keep tuned, and we'll try to explore this question of network adequacy as it develops. Thanks to our friends at WellPoint for helping us put this program together. Thanks to our emergency panelists who filled in so greatly, I think. And thanks to you for asking all the questions that we have tried to address. So if you'd join me in thanking our panel, I would very much appreciate it.